Good afternoon, everyone. Welcome to today's Journal Club. So the topic that I have selected is this is basically a meta-analysis on endoscopic management of leaks and fistulas after bariatric surgery. This has been published recently in Surgical Endoscopy and has been authored by Rogalski and his team from Poland. So as we know that leaks and fistulas are major complications of bariatric surgery that increase mortality and morbidity. And the incidence of leaks after sleeve gastrectomy is around 1%, but in some studies it has been even up to 5 to 6%. And that after Roux-en-Y gastric bypass is slightly less than sleeve gastrectomy, but even here some studies have reported up to 5% leak rates. So we know that when a leak persists for some time, it becomes a fistula. And traditionally, in any anastomosis in surgery, the treatment of a leak or fistula has been mostly done by surgery. And recently, we have also used radiology and endoscopy for management of leaks or fistulas. As far as bariatric surgery is concerned, any reoperation is extremely difficult and risky, especially when the patient is unstable. So, when the patient is in sepsis. And therefore, endoscopic management has been gaining importance very rapidly in this field. Various options of managing leaks are there, like self-expanding metallic stents and plastic stents, various kinds of clips like over the scope and through the scope clips, tissue sealants like fibrin glue and cyanoacrylate, various suturing systems like overstitch, and various internal drainage techniques, which I'll come to later. But mostly the published reports are all mostly case reports and case series, and there is no randomized trial till date. So these authors, they did a meta-analysis and a systematic review of self-expanding stents, clipping techniques, and tissue sealants, where these modalities have been used as a primary strategy in the treatment of leak or fistula after bariatric surgery, namely sleeve gastrectomy, gastric bypass, and gastric banding. And their aim was to assess the technical characteristics of these modalities, their success rates, and the incidence of various complications. They used a Medline and Scopus database search from their inception to February 2019. From the initial review of the literature, the authors found that the definition of leak and the various time intervals, that is acute leak, early leaks, late and chronic leaks, these definitions have varied very significantly in the literature. And there is no universal definition of what a fistula is. Somewhere it has been described as a late or chronic leak, and these terms have been used interchangeably, leak and fistula. So what the authors have done in the inclusion criteria, they have defined leak and fistula together, been defined as endoscopic or radiologically confirmed dehiscence of anastomosis or leakage of GI content from a surgical joint between two hollow viscera or through a suture line around an organ, or the presence of a luminal content or collection next to the anastomosis. So for this review, they have considered only full text articles which were focused on either stents or tissue sealants or clipping techniques and were published in English. And the eligibility criteria were randomized trials, non-controlled clinical trials, observational cohort studies, and case series, which included at least 3 cases. And this was limited to sleeve gastrectomy, Roux-en-Y gastric bypass, and laparoscopic adjustable gastric banding. The exclusion criteria include that studies evaluating only combined endoscopic methods were excluded, and studies where there were any clear data, without any clear data or description of therapy, and studies focusing on endoscopic methods other than stent or clipping technique or tissue sealant application were also excluded. The meta-analysis of studies on stents included only studies where the frequency of stent migration was mentioned. So the data have been compiled and the data of stents, clipping techniques, and tissue sealants, they were analyzed and presented separately. For this, the authors have used two softwares, Stata and PQ-Stat, and a p-value of 0.05 was considered significant. So coming to the results, the initial search on the initial search led to a finding of about 3,757 records, and ultimately 65 relevant articles were selected and reviewed for this report. Of these, 40 articles were related to stenting, 17 related to clipping, and 10 related to tissue sealants. So there were 40 studies involving 493 patients that reported stents and that reported the use of stents for leak or fistula. And the time from surgery to leak diagnosis was reported in 16 studies. And it ranged from, this is the median value. So the median value ranged from 4.6 to 142 days. So basically the range is from 3 to 252 days. The time from diagnosis of leak to stent placement was reported in 6 studies, and it ranged from 3 to 367 days. And time from surgery to stent placement was reported in 6 studies, and it ranged from 7 to 395 days. Stent duration was, the duration for which the stent was placed has been reported in 22 studies, and it ranged from 14 to 341 days. The most common location was the gastroesophageal junction near the proximal end of the staple line, or the distal esophagus, or the upper one-third of gastric stump. A mean defect size was reported only in one study, and it was 1.18 centimeter. Successful leak or fistula closure was reported in 92% cases. And on subgroup analysis, the success rate in sleeve gastrectomy was 92%, and in Roux-en-Y gastric bypass was 96%. And stent migration rate was very high, in the order of 23%, and the range was 19 to 28%. So clipping, there were 17 studies involving 98 patients that reported clipping. And these patients were aged 21 to 67 years, and surgery to diagnosis of leak. The time from surgery to diagnosis of leak was reported in 13 studies, and it ranged from 1 day to 38 years. And there were 10 studies that reported presentation within 1 month. So the most common presentation was around 1 month. In one study, 4 out of 19 patients were asymptomatic, and they were diagnosed while doing a routine control imaging examination. The fistula was diagnosed there. So the most common location again was the proximal staple line, and and there were some gastrogastric fistulas and gastroesophageal junction. So size of leak or fistula was reported in 6 studies, and it ranged from 3 to 22 millimeter. Successful closure was reported in 67% of cases where over the scope clips were used, and where other clips were used, the success rate was almost similar, 69%. But this group had a very small sample size. So there were 5 studies that reported need for additional treatments after primary OTSC therapy to achieve success. And additional treatment was defined as either multiple attempts with over the scope clips, or other endoscopic therapies that included stenting, standard clips, glue, or suturing. And in 3 studies, the patients required surgery after clipping. So various complications related to the OTSC clip system were reported in 2 studies, and it included anchor migration in 1 patient, gastric stenosis in 1 patient, and anchor blockage within the clip in 1 patient. So the next modality, tissue sealants, has been reported in 10 studies involving 63 patients, and all of them used fibrin glue. And the time from surgery to sealant application ranged from 1 to 144 days. And of these 6 reports, the median of 6 reports was around 12.5 days. The access of sealant delivery was either endoscopic, that was reported in 8 studies involving 25 patients, where the success rate was 100%. And in some studies, it was combined with percutaneous and with percutaneous technique. This was there in 2 studies involving 38 patients, and the success rate was slightly low here. And obviously, these that indicates that these were more difficult patients, and that is why they required a percutaneous delivery in addition to endoscopy. So some authors passed a cytology brush into the fistula orifice to clean away debris before application of glue. So on an average, the patients required 2.3 sessions of tissue sealing, but about 45, almost for more than 45 patients, 45% patients had success with after a single session of glue delivery. In most studies, the sessions were repeated after every 2 to 3 days. And the volume per session was reported in 6 studies, and it ranged from 2 to 10 ml with a median of 4 ml. Complications was reported in just 1 study, and it included pain and fever in 3 out of 24 patients. The reasons for failure were large orifice of fistula or due to patient non-compliance. Some patients did not appear regularly on the scheduled sessions. And the cost of fibrin glue is considerable. However, it is more than 5 times lower than that of stent and more than 6 times lower than that of over-the-scope clips. Other tissue sealants include cyanoacrylate and Surgisis. Surgisis is like Surgicel and Fibrillar, what we use in our OTs. So cyanoacrylate is it is even less costly than fibrin. It is 6 times less costlier, but it has got some. It is very brittle and has some may have some pro-inflammatory activity, and there is some possible damage, risk of damage to endoscopes because of rapid polymerization of cyanoacrylate. So it is not used used very frequently, and it has been reported in few studies, but mostly as combined therapy, that is after surgery. So not as a treatment of leak or fistula. For cyanoacrylate, the volume required is also less, so it is about 0.5 to 1 ml for 1 session. Surgisis also has good efficacy, but here the problem is that the delivery is difficult because it comes like in gauze-like strips. So some general observations in this meta-analysis were that septic patients with uncontrolled leaks or peritonitis that should be treated surgically, and patients that are usually taken for endoscopic therapy were all hemodynamically stable. And in many cases, the leak was controlled by percutaneous drainage. For large leaks and fistulas, self-expanding stents were used, and stenting for at least 6 to 8 weeks were recommended by most authors. The common symptoms reported by patients who had stenting were mild retrosternal discomfort, nausea, and excessive salivation. However, the salivation resolved spontaneously after a few days. Various types of stents are available nowadays, covered, partially covered. Okay, stents that are used for, mostly the stents are used for esophagus, but recently stents that are used specifically for sleeve leaks have come into the picture. But an analysis of the relationship between stent type and frequency of stent migration was not possible here due to the large variety of stents used. And for fistulas that were less than 2 centimeters, clips were used, and fibrin glue was effective only for very thin and clean fistulas. The strength, according to the authors, the strength of the study is that it is the largest analysis till date of efficacy and safety of endoscopic treatment of post-bariatric leaks and fistulas. Of course, it has some limitations that it was highly, the studies were had very high heterogeneity, and there is lack of prospective studies. and it is very possible that there is a risk of publication bias. So the authors would only publish the reports where they were successful. So this high success rate of around 80 to 90% may not actually reflect what is in the real practice. The authors concluded that the maximum evidence on endoscopic therapy was there for self-expanding metallic stents. However, the frequency of stent migration was very high. For fistulas and leaks less than 20 millimeter, uh, clips, preferably over the scope clips, can also be used. An application of fibrin glue allows closing of narrow fistulas. However, this may require multiple sessions. The authors have said that there is a need for RCTs, but uh, an RCT in this area is really unlikely because let's say that the sleeve in high volume centers, the leak rate is around 1%. So just for including one patient for endoscopic therapy, 100 patients of bariatric surgery are required. It is unlikely that we'll ever have any RCT here. Let me tell you that actually this is not an ideal article for presentation in a journal club, because this is a meta-analysis, and it is not even a meta-analysis of RCTs. It is just a meta-analysis of few case reports and case series, and there is hardly any comparative data. The reason I chose this article was that so last week we had a presentation on a similar topic, and sir suggested that we could just dig a little deeper into it. So I wanted to present something which is related to it. I don't think there's any point in the limitations are actually not of the study itself. This limitation is for us, that in the newer procedures have not been taken into account. So for knowing about the newer procedures, we cannot rely on this. But I mean, the authors always have the freedom of choosing the cohort of patients that they want to meta-analyze. So what I decided that I would like give you an overview of the more recent topic, the more recent endoscopic approaches. Okay, so I found this review on endoscopic approaches to leaks and fistulas. So this is by De Mora et al. And I'll just give you a brief overview of what these things are. So here they have said that GI defects can be of three types: perforation, leak, and fistula. Okay, so and what we are dealing in bariatric surgery is mostly leak and fistula. So perforation is mostly encountered while doing endoscopy. Okay, so that is not what we'll talk about. And authors have said that the endoscopic techniques can be broadly classified as closure techniques, covering techniques, and drainage techniques. Okay. So closure techniques include clips, endoloops, and endoscopic sutures. And these are most commonly used in perforation. So we have, suppose we are doing an endoscopy in a patient and there is an iatrogenic perforation. So these methods are most useful there. So clips are used for small perforations. Okay, and again within clips there are over the scope and through the scope. So for very small perforation we can use through the scope clips, and for a slightly larger perforations we can use the over the scope clips. For even larger perforations we can use an endoloop and secure it with a clip. So that is a combined therapy. And endoscopic suturing can close perforations as big as 5 centimeter or even larger perforations. So coming to the covering techniques, this includes stents, tissue sealants, and cardiac septal defect occluder. And drainage techniques include endoscopic vacuum therapy, pigtail drainage, and septotomy and balloon dilatation. So the basic principles of the management of any anastomotic leak or fistula is that undrained collection should be drained radiologically. So it can be either radiologically, surgically, or endoscopically. And whenever we are using an endoscopic approach, we have to determine the appropriate approach for closure. Okay, so while for determination of this appropriate approach, we have to consider various things like the defect size, the shape of the margins, the viability of the surrounding tissue, whether it is infected, ischemic, or whatever, and also the location of the wall defect, whether it is in the esophagus or in the stomach or duodenum or in the colon, whatever. So, and also we have to treat any distal obstruction. Okay, so for this we can use either a balloon dilator or luminal stents. And when we have diagnosed, when we have identified the leak site, if there are any foreign bodies, we have to remove them. For example, any loose staples, any sutures, or if there are external drains close to the defect, we have to remove them. And we have to remember that the success rate decreases with interval between surgery and endoscopic treatment. And in one study by Christoforou et al., they have reported that the success rate was 76% at 1 month, and it reduced drastically to 48% when the interval increased to 6 months. So for sleeve gastrectomy leaks, the incidence, as I told earlier, was has been reported in up to 5. An incidence of up to 5% has been reported, and the most common site is along the superior staple line, just below the gastroesophageal junction. The best techniques of treatment of treating sleeve gastrectomy leak is use of covered self-expanding metallic stent and external and endoscopic internal drainage. So when for acute leaks that is less than 7 days, that when the leak is diagnosed very early within 7 days, or even for early leaks less than 45 days, we can use covered SEMS. For acute, covered SEMS is the most preferred. For early leak, it is slightly controversial. Okay. So better results are found when the stents are when specific stents which are designed for sleeves are used for as opposed to esophageal stents. So as I said earlier, the most of the stents that we have in the market, they were designed to manage esophageal perforations during esophageal surgery. Until a few years back, we were using these stents even after bariatric surgery. But nowadays we have some stents which are specifically designed for bariatric surgery, that is which can be placed in the stomach within the sleeve. Okay, for example, mega stent. So better results are achieved when these stents are used for management. And for drainage of the extraluminal content, that is the collection, we can either do that percutaneously, but even endoscopically this is possible. So we can just introduce the endoscope into the cavity. If we can identify the fistula or the leak site, and we can enlarge the leak site and enter the cavity and wash and irrigate and suck out all the contents there. For late and chronic leaks, internal drainage is the best method of treatment, and this can be done, as I said earlier, by 3 techniques: septotomy, pigtail drainage, or vacuum therapy. So a septotomy is done only if a septum is identified between the collection and the gastric lumen. And the idea of septotomy is to form a communication between them. Okay, so gastric bypass leaks are most commonly seen at the gastrojejunal anastomosis, gastric pouch, and sometimes in the excluded stomach, and rarely in the blind portion of the rulum or jejunal anastomosis. So for acute proximal leaks, that is leaks near the gastrojejunal anastomosis or the gastric pouch, covered stents are most useful. The stenting time that has been reported in the literature is on an average is about 3 to 6 weeks, and the success rate is around 76%. For leaks at other sites of, in case of gastric bypass, stents are not very effective. The biggest problem with stents is migration, and rates as high as 30% have been reported. And for this, to prevent, the migration rate can be lowered by proximally fixing the stents. For this, we can use either clips or endoscopic suturing. But even after fixation, stents have been found to migrate. If there is a distal obstruction, for example, when there is a leak in the when there is a leak just proximal to the gastrojejunal anastomosis because of anastomotic stenosis, so we have to relieve that distal obstruction by doing a balloon dilatation. But we have to remember that the dilatation should not be more than 15 millimeter at a time. And so, or we instead of doing a balloon dilatation, we can just place a stent across the anastomosis. For chronic leaks and leaks with well-defined extraluminal collections, the best treatment again is internal drainage. So coming to fistulas now, fistulas are basically when leaks persist for a long time, they become fistulas, and they are very difficult to treat because there is an established epithelial tract near very unhealthy tissue. So the first thing that needs to be done is de-epithelialization of the tract. And this we can do either using argon plasma coagulation or brushes. As I previously told, we can use a cytology brush. Okay. So I just would like to point out here that last week there was a doubt regarding this, that we thought that APC was used only for bleeding control, but it is actually used for de-epithelialization before doing the actual closure or before doing any kind of drainage procedure. So we have seen that for fistulas, SENs are not as effective as in leaks. Okay. And clips and suturing, they give good immediate results, but they frequently recur. So they are not used for fistulas. And the treatment of choice, as I have said earlier, is internal drainage, which can be either pigtail drainage, vacuum therapy, or septotomy. So we'll see these modalities one by one. So coming to pigtail drainage, or sometimes we use what is called a nasocavitary drainage. So what we do is under general anesthesia, this is basically a double J stent that we use in any biliary surgery in general surgical practice. Okay, so under general anesthesia, a straight catheter loaded with a guide wire is advanced into the collection, okay, endoscopically. And if first we have to see that the cavity is drained surgically, okay. Suppose that the cavity has already been drained surgically by either by surgery or by radiological percutaneous techniques, then we can just place a double plastic stent, 1 or 2 plastic stents, which are 7 or 10 centimeters long and a 7 French. We can just place the stents across the leak or fistula. Okay. But suppose the cavity outside, that is the cavity outside the leak, if there is a collection there, if it is not clean, if there's pus in that, then just placing a stent is not adequate. We have to place a nasocavitary drain. Okay. So the idea is, it is just like E and BD. Okay. So the idea is we can just give frequent washing. Okay. So after this, we can start oral feeding. And after every feed, we have to flush this nasocavitary drain with 20 to 30 ml saline. And the drain remains in situ for about a month, but the patient can be discharged after 1 week. So after a month, we have to do a CT scan and then an endoscopy. By CT scan, we see if the leak is persisting. We give some contrast and we see if there's leak still. Okay, and we have to verify it endoscopically as well. So if we see that the leak has healed, then the nasocavitary drain is removed. But the double pigtail stents are still left in place for at least 6 months before final removal. So here you can see there's a leak here. This is the leak, and there's already the team, they have placed a stent here. We can see the stent, okay, and this is the endoscope, right? And this is the endoscopic view we can see this is the leak or fistula, and we can see a drain lying outside. Okay, so this drain has been placed percutaneously. Okay, so this is, so here we can see some stents have been placed across the fistula. So these are the pigtail stents. 2 stents have been placed here, and these stents can be seen fluoroscopically as well. Okay, so after some time we see that the stents are there and there is no leak. Okay, so on CT scan, on fluoroscopy, there is no leak, so the fistula has healed. Okay, but we will not remove the stents right now. We'll remove it around after 6 months. Okay, so here's an article by Gonzalez et al, and they have actually compared uh, the 2 case scenarios where endoscopic drainage, that is where a pigtail drainage has been used as a first line treatment or a second line treatment. Okay, so they had around 400 post sleeve gastrectomy fistula patients, and of these 22 patients, that is all patients after year 2013, they had first line endoscopic drainage. Okay, so whenever the leak was diagnosed, the first treatment modality that was offered was endoscopic drainage. So this cohort is around 22 patients. So prior to 2013, their initial management for this cohort of patients, for any fistulas, was something different. Okay, so it could be either, so mostly it was stent placement or clips. Okay, so they did some closure technique. Okay, closure management or covering technique, not drainage, and they had success in about 49 out of 77 patients, and 22 patients did not respond to this treatment. So these 22 patients have been compared to these 22 patients. So these 22 patients, they underwent endoscopic drainage as a second line treatment. Okay, and these 2 groups have been compared here, and we can see that the baseline characteristics, the demographics they are comparable between the 2 groups, except a few things. In the second line group, more patients had surgical drainage, which is understandable because these patients, they were referred directly to these, and before undergoing any percutaneous or any surgical drainage, endoscopic drainage was performed. Okay. Also, these patients had more collections, obviously because their collections were not drained here by other means, and they had they had more larger collections, and more collections with pus. Okay, which is understandable. Okay, so coming to the outcomes in these 2 groups of patients, we can see that the complications, uh, the first thing is that the final efficacy was comparable between the 2 groups. Okay, so healing rate was ultimately equal whether endoscopic drainage was used as a first line treatment or a second line treatment. But when it was used as a first line treatment, the complications after the first endoscopy was much less. Also, and why was this? Because these complications mostly arise due to use of self-expanding metallic stents. So either stent migration or bleeding or perforation or whatever. So these are the complications that accounted for this discrepancy. All right. Also, stricture formation, delayed stricture formation was more when endoscopic drainage was used as a second line treatment. So if we use it as first line treatment, the outcomes are better. Early rehospitalization was also less when this was used as a first line treatment. Again, this is understandable because there were complications after the first endoscopy, that is complications due to SEMS or clips or whatever. These patients were readmitted more. Expectedly, the median number of endoscopies was higher or was lower when it was used primarily. And median time to healing was also less, although this was not statistically significant, but we can see there is a definite clinical advantage of using endoscopic drainage as a primary modality. Okay. So this median time, it includes 6 months of follow-up. So that is 180 days. So if we subtract here from 180 from here, so it is 46 days. So the median time of healing by primary endoscopic drainage is around 46 days. The authors have mentioned some other studies where pigtail drainage has been used, and we can see there were total 146 patients where this was attempted, and the median number of endoscopies was 3.5, clinical success rate around 90%, mean treatment duration was almost 2 months. But you see, there's a very low rate of complications. So the authors have suggested an algorithm for post-sleeve gastrectomy fistulas. So if the fistula is not drained, the first thing is we have to do a drainage. So we can use a nasocavitary drain and a double pigtail stent directly. And if it has already been drained, then we can go for other modalities. So if the orifice is very large, that is more than 2 centimeter, we can use just double pigtail stents. If it is small, we can use stent or clips. If it is small but there is a delay, then we would not use clips. Then we'll use just the pigtail stent, double pigtails. And if there is a stricture associated, then we can use a nasocavitary drainage along with a stent. So coming to the next modality, septotomy. The principle here is that there is a pressure gradient. So inside the stomach, the pressure is high. So that increased intraluminal pressure drives the gastric contents towards the perigastric collection. Okay. And the idea of septotomy is to address this pressure gradient so that there is equalization of pressure, so that there is no further drainage of gastric contents outside. Okay, so what they do is that the gastric remnant has to be dilated. So again, here the distal stenosis has to be taken care of. So this can be done using a double balloon. Can be used by using a balloon dilatation. And after this, the fistula tract is incised and enlarged. Okay, and this allows for internal drainage and epithelialization of the cavity, which then heals by secondary intention or by granulation. Okay, so let us see. These are the pictures here. So this is the fistula orifice. Okay, so the first thing that we have to do is remove the loose debris here. So with using a forceps, we are removing all the staples here. So here the septum, once the septum is identified, it has to be incised. So this can be incised using a needle knife or argon plasma coagulation. Okay, so we'll see that argon plasma coagulation is better as it causes less bleeding. But normally when we use APC for bleeding control, we do it from a certain distance. We don't actually touch the surface that is bleeding. Okay, but here we have to go very close to the surface, and then only it can be used as an incising tool. Okay, so here we have seen, and here the balloon dilatation has been done, and this is the final appearance of the cavity. So this is an article where 9 patients have been reported to have undergone septotomy, and they were diagnosed at a mean of 8.6 weeks after. So septotomy was done at a mean of 8.6 weeks after diagnosis of leak, and the collection volume range from 3 to 10, size range from 3 to 10 centimeter. So all these patients had previously undergone other modalities like percutaneous and conventional endoscopic treatment like clips and stents. So the procedure was done under GA or propofol sedation, and carbon dioxide insufflation was used. So for all these endoscopic procedures, nowadays we prefer to use carbon dioxide insufflation because there's a cavity outside, okay, outside the lumen. So if carbon dioxide goes into that cavity, it is easily absorbed. Also, it can lead to pneumothorax and all. So carbon dioxide is can be readily absorbed, and if we use air instead of carbon dioxide, these patients can land up with pneumothorax or pneumoperitoneum, which can be very uncomfortable. So on an average, these patients had 2.3 sittings of for septotomy, and the mean procedure time was roughly about 1.5 hours. 3 patients experienced bleeding, but all these 3 patients, the incision was done using a needle knife. However, the bleeding could be managed with endoclips and no transfusion was required. All the patients had symptom resolution, but 3 patients did not have radiological resolution at the time of publishing this report, but they were asymptomatic. And the mean follow-up was around 20 weeks. So these authors also have suggested an algorithm, and so if the patient is unstable or peritonitis, and there is a drainable collection, and if it is more than 2 weeks, then the patient should be subjected to endoscopic septotomy. So coming to the final modality, endoscopic vacuum therapy. This is the in thing now, and not many reports are there in the literature. So here, so basically what we do here is we use the principles of negative pressure wound therapy to an anastomotic leak or fistula. So under GA or sedation, what we do is we insert a nasogastric tube through one nostril, and the other end is retrieved through the oral cavity. And to that end, a polyurethane sponge is fitted to the nasogastric tube, and it is sutured. Okay, and we have to take care that all the perforations of the tube are covered by the sponge. There should not be any perforation that is left open. So after this, the distal end of the tube is grasped with forceps, and together with the endoscope, it is inserted. And under direct visualization, the sponge is positioned over the defect. And the other end that comes out through the nostril, that is connected to negative pressure of minus 125 millimeter mercury. And then the scope is removed. It is a very effective therapy, but the only problem is that the sponge has to be exchanged every 3 to 5 days. Just like in wound therapy, the sponge collects all the all the pus and debris there. So it has to be exchanged every 3 to 5 days until healing of the defect. So this technique can be done in various ways. So this is a picture where an over tube technique has been used. Okay, so first is the endoscope is inserted through mouth, and the stomach is inspected, and we have inspected the cavity. Okay. After this, an over tube is placed over the endoscope, and it is kept in situ. Now, a nasogastric tube is inserted through the nostril and brought out through the mouth, and to this end, this sponge is attached. And then this is again, the sponge is inserted through the over tube, and it goes and lodges here. So then the outer end is connected to the negative suction, and we can see it uses this negative pressure to suck out these liquid tissues, these collections here, and gradually there is a decrease in the size of the fistula. Okay, so every time we change this, every time we do this, we insert a new sponge, the size of the sponge has to be shortened. This is a review of various studies where endoscopic vacuum therapy was used. And we can see there's a total of 189 patients out of 210 had success using, that is, had a resolution of anastomotic leak using this, that is about 90%. Okay, and for esophageal perforations, the success rate was 96%, and the duration of therapy was on average 17 days. This is a more recent review published in 2019, and here 422 patients underwent vacuum therapy, and 87% had successful results. So as you can see here, most of these patients had esophageal surgery. Okay, so there's one on duodenal surgery, and there are only 2 studies where bariatric patients were subjected to endoscopic vacuum therapy, and this study where only bariatric surgery patients were included, and we can see the success rate is around 85%. So lot of algorithms and summaries are there. So just to summarize a bit, for acute leaks less than 7 days, we would most commonly use either stents or clips. For early leaks, we can use a stent, but some studies have suggested that even for early leaks, drainage would be better. For late and chronic leaks, we have to use some endoscopic drainage procedure and not stents and clips. And we can use any of these 3: septotomy, balloon dilatation, or vacuum therapy. And sorry, septotomy, pigtail, and or vacuum therapy. There, I didn't found any comparative trials among these 3. So I think it's mostly a matter of personal preference. The take-home message would be that there is very limited data yet to suggest any recommendation or any such algorithms. And we can use these algorithms, but in any case scenario, we have to use clinical judgment and what uh, uh, what procedure we are comfortable in and what device we have in our institutes. Thank you. And today we have a lot of celebration going on around the country. In my part, this is the Bengali New Year, and I would like to wish all of you a very happy New Year. Thank you.
So I think it's an excellent presentation, Aditya, and I personally learned the endoscopic suction therapy.
Yes,
Something which is new, which I had obviously did not know.
thank you, sir.
What we did in one of the cases, I'm just sharing one of my experience. We had a leak on a 5th day, and there is a small collection in the paragastric area close to the splenic pole, upper pole of the spleen.
Yes,
And somehow our intervention radiologist was not able to reach up to that area. So it was not possible for us to drain radiologically. And patient was not in the sepsis, though he had some tachycardia, but not frank sepsis. So what we did an endoscopic ultrasound. We did not pass our endoscope through the hole, but what we did, we left a nasobiliary drain
yes.
through endo ultrasound into the collection.
Yeah,
And we applied suction to suck all the muck there, all the
right.
collection. It was around 45 to 50 ml of collection on CT scan. So
Okay.
we sucked all the collection with the suction there.
Yes.
And then we kept that nasobiliary drain there for some time. And in 3 weeks' time, it all healed. So, as you rightly said in the last slide, that I think it's very, very difficult to have a algorithm which will apply to all scenarios in all centers. Ultimately, we have to see in your own practice where you are practicing, what are the expertise available, what are the instrumentation available,
Right.
and keeping in mind some basic principles of surgery. The like whether there's a distal obstruction present or not, what is the condition, local condition of the tissue, All these factors have to be taken into account before you decide what protocol you want to follow. We have gradually changed. In the beginning, we were very, very enthusiastic about putting a stent immediately after a leak. And by talking to people around, and Sandeep also, what I realized that Sandeep is also not a great fan of stents. And then we realized gradually that, yeah, it's not necessary that in all patients you need to put in a stent. But I must confess that initially our practice was to put more and more stents in all patients. Probably we were being guided. There are different pressures of private practice, and we tend to sort of maybe take some decisions which are more practice oriented rather than scientific at some point of time.
Yes.
Top. So I'll just come to your comments after I just summarize Aditya's point. I mean, first of all, let me congratulate Aditya for a really wonderful presentation. I was actually looking for a long time. And again, as I said, it's probably again one of the best I've ever heard on this topic. And I'm glad, Aditya, besides covering your own one journal club article, you went on to the related articles and covered the whole gamut of it in a really wonderful way, putting things in perspective. Now coming to what now the issue with all these endoscopic therapies is that success rate is not 100%. You would realize that.
Yes.
Okay. Now, so and you would have to take into account the trauma of repeated endoscopies. I've taken personally accompanied a patient to the endoscopic suite and seen the trauma they suffer when they undergo endoscopy for any intervention. I remember a patient in which a clip was planned and how traumatic it is. Now, in our own experience, you would be very surprised that when Deep is rightly said that I'm not a fan of SIMS. And I will not agree that private the pressures are more in government, because I'll tell you why. All these patients would go to various bariatric surgeons, including the top shots, and have them call us, and they say, oh, they would say, stents have to be put. Why are you not putting in? So pressures on us were equally bad, but uh, as I said, always said in our own experience of leaks, we have been fairly successful with conservative management, and the same principles we have applied sometimes, putting a suction on the pigtail drain. And I have always somehow believed that radiological healing may not be absolutely essential. We had
Yeah.
a patient from Bulandshahr or Meerut who would not believe his CT showed leak after 8 weeks of conservative management. We fed him. He became all right, because I always used to say, and it used to be very unscientific saying that time, that this cavity is a part of the stomach now. So even if you're eating it, going to the cavity, it comes back because it has been totally fibrosed now. If the patient is not in sepsis, we have continued feeding and we have really discharged the patient with the radiological evidence of leak. So again, as Aditya said, sometimes you don't publish because your results are not as good. So we were thinking of publishing because almost that time we had a 90% rate of healing. And then we had this chronic leak, which after a very successful surgery died. I remember, Deep, I was sitting with you that time
Yeah, yeah.
in sports club. So what I'm trying to say is
I know the
all
family.
these options are a very nice, especially I'm very impressed with the endoscopic back therapy,
Yeah.
the endoscopic taught me and drainage, but I'm not a big fan of covered therapies like stents and clips. And I personally believe the way to go in chronic fistulas will be that. Now, problem with acute fistulas, I think we need a systematic review of conservative management that is without any such sense and all thing, along with sense. I mean, so we need two groups to be compared. My only question from Aditya you is, in the studies you looked at the stents, which have looked at the stents,
Yes.
what did they do when the stent migrated in 20%? What happened to the fistulas in which 20% of those cases the stents migrated?
Uh, so the reviews that I have read, I didn't find anything written on this, but I might just
Yeah, because
find something if I
because
go
that
to
is
the Google
important.
studies.
So when I so very very important. That is because I was very giving few lectures on this almost repeatedly. I had about 4 or 5 presentations at various forums, Dubai and all. And when I looked at the literature, the healing rate was same in those patients who had a stent which was migrated. That means probably the stent was not necessary. Again, with the similar principles of drainage. So if your collection has been drained properly by pigtail, you don't have a distal obstruction, you don't have sepsis, the fistulas would heal. Uh, Only issue is when you have a septum where it is blocking the actual drainage. I think the first patient which we lost was actually when we were totally inexperienced, and I remember now that endoscopy showed a septum, and probably we are totally inexperienced. That was 10 years back. So I would be very enthusiastic about in chronic fistula septotomy, EVT, pigtail drainage, but I am still not very convinced about putting a stent in early leaks. And I'll give you another example of a case who lives near our house only. I mean, unfortunately, our leak sometimes. That was not a frank leak. He had a gastrocutaneous fistulas 3 months after surgery. Okay, so he developed a small port side infection, repeated discharge, and we did a CT which showed a gastrocutaneous fistula. So उस समय Dr. Mishra से मैं काफी advice लेता था because we were also involved. So he said do nothing. We did nothing. So unfortunately, he got posted to Mumbai, or fortunately, which I don't want to say, and some big shot in Mumbai operated him. Then he was posted back to Delhi. He had a gastrocutaneous and a colocutaneous fistula. Okay. Again, I went to Dr. Mishra's office with him because now he says do something. So, and he was cursing that surgeon, saying these guys operate just for BMWs and Mercedes. And I could see 6 luxury cars standing outside his nursing home, and that's why he operated. Anyway, I told him, and I took him again. And then Dr. Mishra again said, do nothing. And you won't believe that even with all that CT imaging showing colocutaneous and gastrocutaneous fistula, and he was not in sepsis, luckily. He was a diabetic. He healed. So I am just sometimes wonder that some of the cases were being so aggressive with endoscopic management options, where fistula may drain on its own, heal on its own. So that's all I want to say. I am really impressed by the presentation, and obviously the new therapies are very exciting. But again, the context of patient trauma, cost, and the rate of healing itself with such non-fancy things, we really have to compare in a large, meta-analysis or a systematic. What you're saying is right. No art surgery is possible. We need to look at like people like me, maybe, or some more who are not using these therapies. I am aware. Dr. Nagoya and from US, she has published a series on total conservative management without stents. I'm sure we can find at least 10, 15 articles on them. And maybe if somebody is interested in writing a systematic review, this is a very good idea to compare these two.
So what I said, Sandeep, was that I didn't say that the private sector has more pressure. What I said, there are different pressures. You have a different set of pressures, and in private sector, sometimes it becomes imperative to do something, because you can't keep the patient in the hospital for a longer duration because
you're right.
So many
you're right.
patients.
I think the only advantage we have is we can keep the patient admitted. We have that advantage. That advantage.
Yes. So I said with the different pressures.
I agree with that.
Only that. And but again, as I said, that science should by and large remain same in any setup. But obviously, sometimes you need to do little modifications according to where you are practicing, what you are doing,
exactly,
availability, as Aditya also rightly said. So we must be like as I said before, I was not aware of this vacuum therapy, endoscopic vacuum therapy. And we have now recently used for the wounds. But I was not aware of endoscopy. It seems like a very promising thing. And any endoscopic intervention, I think, should be done under proper anesthesia to make it more comfortable for the patient. Otherwise, a lot of trauma. I completely agree with that.
With the trauma, the healing can be worse than the cure sometimes.
Yeah, absolutely.
Any more questions?
Fantastic.
Any more questions?
What we have to remember is that most of these data are from esophageal surgeries. These are not data based on bariatric surgeries at all. Most of the data is from especially on the data about vacuum therapy and all. Most of these patients.
3 patients, I would, Sandeep, 3 patients, 1 recto-vaginal fistula post low anterior resection, and 1 esophageal fistula, lower end esophageal fistula after a radical gastrectomy, and another one is a colonic fistula, right-sided, colocutaneous fistula. This is, I'm talking about around 7 to 8 years back. And what we did in these patients that time, if you remember, the fistula plug used to come. This was made by Cook, and in the enthusiasm, we used in these 3 patients, and two of them, one the esophageal and the rectovaginal fistula, they both healed. You see what mistake we made in the radical gastrectomy was that I did a hands-on continuous closure of the distal esophageal stump before we fired the circular stapler to do the esophagoduodenostomy. Because of the continuous suture, what happened once we fired the staple, the rest of the suture line of the esophagus opened. You know what I mean? Once fired the
Yeah.
circular stapler, it cut through the staple, the suture line,
Yeah.
and it gave way on one of the ends of the lower end of the esophagus, and that formed a fistula. So there we did an
Okay.
endoscopic plugging through the
Okay.
fistula plug, and it did work. Similarly, for the rectovaginal fistula after low anterior section, it worked, but it did not work for the colocutaneous fistula. That was probably an overkill. It didn't require to do it. That also is an option which I think one should explore in some of these fistula where there is no significant collection outside, and if you can plug them with the fistula and see what happens. That is also an area of which can be explored.
So the only comment I would say is when we had tried endoscopic means in one or two patients, our endoscopist should always say admit this patient and put them on long-term antibiotics, even when you're using glue or something, because sepsis is an important part. Even if there's a low-grade sepsis around the fistula, it will not let any endoscopic therapy work. Aditya, could you find anything about adjunct therapy with these endoscopic options, antibiotics long-term or something like that? Because our endoscopy used to say that.
No, so I didn't. I mean,
No.
antibiotics, adjunct, like these modalities have been used in combination. So, in fact, most studies nowadays would use a combination of therapy.
Okay.
I didn't find anything.
Anybody else have the question?
Yeah, Dr. Aditya, nice presentation. I have one question, if I could recollect from the last slide.
Yes.
For the negative pressure therapy endoscopy, that they have recommended it for the late leaks, not for the early leaks. What is the reason for that? If you see the last slide, algorithm they have given.
No, even for so this
No, please,
algorithm
can
that
you
I gave
show
you,
us the
that
algorithm, negative
yeah,
pressure therapy article
algorithm that I gave, that was given by given in one of the reviews. But in some studies, as I showed you in one study, even nowadays, even preemptive negative therapy, negative pressure therapy is being used. Even preemptive, like you are suspecting that, suppose you do a follow-up endoscopy and there's not a frank leak, but you see some areas of ischemia and all, and you suspect that it might give way. In these patients, they are using it as a preemptive therapy.
No.
So
Then where to keep the
I
sponge?
will answer.
Where to keep the sponge? Yeah.
I will answer. Can I just say one thing?
Yeah.
Yes.
The endoscopic vac and the septotomy and all that cannot be used in acute leaks. Septum will form only in chronicity, and washing and all and deepithelialization will happen only in the chronic leak.
Yeah.
All those options of a drainage are obviously for the chronic leaks. Early leaks, if you do these things, you will increase the size of the leak, and maybe that time adhesion not forms.
Absolutely.
So
similarly, like the abdominal wound, abdominal fistula, it is for very complicated wounds, not for routine wounds. Because they will, as Sandeep said, they're likely to increase the size of the hole, and they're very cumbersome, and very expensive as well. This machine, the sponges needs to be changed. They're very expensive and very cumbersome. So they're needed for the more complicated problems.
So
Hemant, what was used in Indore? What was your protocol in Indore for acute leak?
Yeah, we saw few cases. So in one, we were using stents, sir. Stents.
Okay.
Fully covered stent. It is mega stent we were using. Though Dr. Nato came there and he demonstrated this endoscopic internal drainage.
Yeah. Nato is the
he
father
frequently
of all
comes there. Yeah, but the
Sandeep,
problem is that
I would leave, Sandeep. I have to actually have another commitment. I'll leave. Thank you very much.
Sure.
I really enjoyed.
Thank you so much, Sandeep. Thank you for the valuable comments and
no. I really learned a lot. Thank you so much. Thank you.
Thank you, Deep sir. So endoscopic internal drainage is a new thing, which is coming up very fast. But in the acute leaks, again, there is a problem because the cavity which you are draining inside should not be communicating with the outside. Because most of the time we have to go for laparoscopic lavage and drainage of the pus collection inside the abdomen or the seropurulent fluid, whatever it is. So if you place a drain and this cavity is also in continuity with the drain and you internally also drain it with the double pigtail stand, then due to the low pressure in the abdominal drain, this will not heal. So for the pigtail drainage, that is endoscopic internal drainage, your cavity should not be communicating with outside. That is the one important thing which we should know.
That's true. That's true. Just one more point which came to my mind was in one of the slides, Aditya said, when you do an endoscopy, just check there is no external drain lying near the cavity, near the hole, because that
Yes,
won't
sir.
heal.
Yeah.
It's a very,
Yeah.
very appropriate thing. I'll tell you why. That's why
Very,
I'm big believer in shortening the drains. When I was in SR in Vallabhgarh, I did a open ureteral lithotomy. That was like, you can call when 94. Okay, so in one of the rural centers, so I did an open ureterotomy and patient, we did, that time I think double J stents all were not easily available in those areas. So I just closed it, interrupted sutures, and the patient had a drain, tube drain. So patient kept having leak. He was passing a lot of urine, but leak. So one of the consultants came for the rounds one of the weekends or something. He said, just remove the drain. It'll be all right. And we removed the drain and nothing happened. So sometimes the drain tip sits on the hole, it will never allow it to heal.
yes.
So
Yes.
that's why it's probably good to shorten it. And as Aditya rightly pointed out, the drain itself can act as a deterrent or an impedient for drainage, for closure of leaks.
Okay. So I
Just one
think
point for
from
the
the
postgraduate, that drain shortening,
yeah.
whenever there's a chronic leak, start shortening the drain because the tract has already formed.
Yes.
Just as a general surgical principle and a learning point from what I learned from my senior agency and also in a whole lot of leaks.
Hold on.
Anybody else has a question? I mean, we're all, I think our faculty input and Dr. Aditya did a really
Very good presentation.
presentation. So anybody else has a point?
Dr. Aditya. Hello, Dr.
Quickly, because I think we are really going very long. Another
Yes,
4 minutes. We finish at 3:15.
Hello, Dr. Aditya.
Anybody?
Yeah. Hi, Dr. Amardeep.
अमरदीप तुम्हारा ना माइक बहुत खराब है मेरे माइक की तरह.
Sorry, sir. Can you hear me, Dr. Aditya?
Yeah, somewhat. Yeah. Go ahead with your question.
Okay. So first of all, very nice presentation. I have one question regarding sealant therapy.
Sorry?
Tissue sealant therapy.
Yes.
I have one regarding tissue sealant therapy.
Yes.
So I want to know what are the criteria to call the patient for second session of tissue sealant therapy.
No, you have to call the patients for you have to call anyway because you have to see endoscopically whether the leak has healed. So a second therapy, I mean, at least a patient has to undergo 2 sittings for the second sitting just to check whether the anastomosis is healed. And if it hasn't healed, then he has to undergo a 3rd sitting just to check.
So you are saying direct inspection through endoscopy
Yes.
is the criteria of second mode.
Of course, clinically, I mean, if the patient is in sepsis, then you have no doubt that it is not healed.
Basically, for sepsis, you are not offering the endoscopic therapy, no? For sepsis, you are not offering the endoscopic therapy. Basically,
Not in sepsis,
we have to inspect
I understand.
leak was.
Suppose the patient has presented with the cutaneous fistula. Okay. So you can follow that whether there is any drainage through that. But even if there's nothing draining through the skin, nothing coming out of the skin, even then, at least you have to call the patient second time to see whether the fistula has healed.
Okay. I have second question regarding GJ anastomosis leak with distal obstruction.
Yes.
So I want to know, you have told that we need to do balloon dilatation before along with putting stent.
Yes.
So can we do both the thing in the same sitting, dilatation with putting the stenting, or first of all we have to do dilatation only, and then call the patient for second or next setting for stenting?
I think it can be done in the same sitting. Yeah.
Balloon dilatation with stenting in the same sitting.
Yes. Yes.
Okay, I think let's wind it up. So I think all of us must learn from how Aditya has presented. The effort is put in is tremendous, preparing such a long, crisp presentation with each slide giving us some information. The delivery pace, I think it's all worth looking at by all of us to learn. And all of us must, because that means we have utilized our time really well. We have learned a lot of new things. So all of us should make an effort, not just do the presentation for the sake of it. Please, all of us, time is precious, so please put in your effort whenever you're preparing a presentation.